I'm basically going to be talking on gram-positive infections, especially as we see them in the ICU. What are the type of gram-positive infections that we encounter in day-to-day practice as far as ICU is concerned? We see a lower respiratory tract infection in terms of pneumonia, blood and stream infections, skin and soft tissue infections, and infections occasionally involving the bone and joints. And then we have patients who come with CNS infection like meningitis, and then surgical patients or trauma patients who have intra-abdominal infections. And then finally, infections which are important as far as gram-positive organism is concerned, that is infection associated with medical devices. So basically, you could have asymptomatic carriers which could be present in the nasopharynx, and then you could have colonization which could be present in the skin or in the IV cannula, and this could at least be a source of infection to various parts of the body, and the organs that can be involved actually are quite extensive, from the heart in terms of endocarditis to the lungs, to the abdomen and to the bones. Now, as far as gram-positive infection is concerned, the last 2 decades have seen an increasing trend as far as gram-positive infection is concerned. And this is basically because of poor activity of the commonly used antibiotics. There's also been an explosion in the use of indwelling medical devices which have promoted more chance of gram-positive infection. There is a continued expression and successful clones have been developed which have led to more resistance. And over the last decade or so, we have seen this term of community-acquired MRSA, which is coming up and causing also a cause of concern, both in terms of community-acquired infection and increasing chances of hospital-acquired infection. The common agents that we tend to see in the ICU are either Staph aureus, coagulase-negative staph, enterococci, and streptococci pneumoniae. The first 3 being the more important one in terms of an ICU setting. If you look at the magnitude of the problem, and if you look at data which is there from our center, overall about 40% of total culture-positive infections at our hospital are due to gram-positive bacteria. So still, in medical ICUs, it tends to be more gram-negative, followed by gram-positive. But when you look at neonatal ICUs, or you tend to look at more of the neurosurgery or neurological ICUs, gram-positive infections tend to be much more common there as compared to gram-negatives. In our center, we find that Staph aureus is the main cause of skin and soft tissue infection and primary bacteremia. Coagulase-negative Staph aureus is also a common cause which is seen, but sometimes there's an issue of how clinically relevant it is in many clinical situations. Enterococci species is the most common which is seen as far as UTI, abdominal infection, and bacteremia patients are concerned in chemotherapy situations. And we have Streptococcus viridans as far as infective endocarditis is concerned. And strep pyogen invasive infection is more common in immunocompromised patients and patients with skin and soft tissue infection. So what are the challenges that we tend to face as far as gram-positive infections are concerned? First of all, a trend towards an increasing tendency of gram-positive infection. Secondly, increasing lines and devices being used, and this leads to what has already been discussed, the formation of biofilms, increasing resistant bugs, and then increasing community-acquired MRSA and nosocomial transmission. And we don't have too many drugs in the near future to treat drug-resistant gram-positive infections. Now, the issue always comes up that why are we seeing a lot of gram-positive resistance? One is, of course, the most important, an inappropriate use of antibiotics, patients overcrowding in most of our ICUs, economic pressures as far as nursing and other staff is concerned, prolonged hospitalization, again the presence of invasive devices, and more chronic, acutely ill, immunocompromised patients. All of this actually tends to contribute more towards gram-positive infections. And therefore, we have a large number of newer resistance terms which are being used. MRSA we're all aware of. We have glycopeptide intermediate resistant Staph aureus, the GISA. And then the more important is the VISA, the vancomycin intermediate Staph aureus, and the vancomycin resistant enterococci, which was thought to be uncommon or rare, but increasing reports are coming up as far as VRE is concerned. What is the evolution? And if you look at the evolution, it's interesting. We had Staph aureus, which was there, and we felt we were able to treat it when penicillin came in the 1950s. But then there was penicillin-resistant Staph aureus. With the subsequently, with the event, there was the introduction of methicillin, and very quickly we found we had MRSAs being reported. And in the 90s, with vancomycin being used extensively, there was the issue of vancomycin-resistant enterococci and vancomycin intermediate Staph aureus. And now we have come to a rather dangerous situation of vancomycin-resistant Staph aureus, which is being increasingly reported from various centers. If we look at MRSA and we look at the worldwide prevalence of MRSA, even in our country, the prevalence varies from about 10 to 25%, but extensively reported from the West, especially from the USA and from Britain and other parts of Americas, even from Australia for that matter. On the other hand, if you look at community-acquired MRSA, and there have been outbreaks which have been reported, and interestingly, even from our country, there have been outbreaks which have been there of community-acquired MRSA, which means that there is an increasing trend of MRSA being present as far as the community is concerned. If you look at ICU data from the West, there is an increasing tendency for MRSA in most intensive care units. This is from the US, and there is also increasing trend of vancomycin-resistant enterococci also being seen in most ICUs from the West. What about resistance in our hospital? And if you look at data, and this is data which has been published from 3 hospitals in Delhi, that is from AIIMS, Safdarjung Hospital, and Lady Hardinge Medical College, and MRSA in skin and soft tissue infection was reported in almost 40% cases of staff as far as AIIMS was concerned, up to 7% as far as Lady Hardinge Medical College was concerned. And all these MRSAs were actually multi-drug resistant. This is from that table, and if you see the factors which actually contributed to the development of MRSA was duration of hospital stay, intra-hospital transfer, features neurological disorder, osteomyelitis, and the use of certain antimicrobial therapy like aminoglycosides and clindamycin. So a number of factors did contribute to the development of MRSA. If you look at these, the data, as far as resistance to other classes is concerned, as far as these drugs are concerned, in the MRSA group, 50% resistant to amikacin was seen, 80% to ciprofloxacin, and there was more than 90% resistance to cotrimoxazole. 62% of coagulase negative staph was methicillin resistant, and overall resistance was higher than staph aureus. However, the data from our center did suggest that they were still susceptible to vancomycin, teicoplanin, and linezolid. But there has been increasing reports of resistance, and this is a paper which was published in 2008 from Calcutta, which again reported isolation of vancomycin-resistant staph aureus from a center in Calcutta. If you look at data from our center as far as enterococci is concerned, 90% of them have a higher load activity against aminoglycosides, and there is about 5 to 10% of them are vancomycin resistant, and this is actually increasing over the years, and sensitivity to linezolid is around 85%. So we are actually seeing an evolving trend of increasing resistance as far as gram-positive pathogens is concerned, and this is basically occurring due to what is known as the methicillin resistance due to the MEC or the MEC-A gene, which is in the penicillin-bound protein 2A, and this actually escapes inhibition with methicillin and penicillin stable beta-lactam. This basically, the clone of this is actually circulating in clinical settings, and this actually leads to further development of MRSA from the methicillin-sensitive staph aureus. The risk factors which actually contribute to the development of this MRSA are advanced age, underlying disease, for example, renal failure, hematological cancer, hepatic failure, the severity of illness, inter-hospital transfer, the length or extended length of stay, invasive devices or procedures, and anti-infective therapy. All of this actually drives resistance as far as ICU gram-positive infection is concerned. The issue of biofilm has already been discussed, and it's also very important as far as gram-positive infection is concerned. It actually prevents, the biofilm actually provides a protective environment for staph and impedes the antibiotic penetration, and therefore allowing the infection to stay for a longer time, and therefore prevents it from being eradicated. As has been shown by Dr. Chakravarti, there is a higher chance of staph leading to the biofilm formation and therefore proliferating in the biofilm, basically occurring by the coagulase negative staph aureus, which is present on the skin surface, getting attached to the device, migrating down because of its special structure that are present on it, which are able to adhere to it, and facilitating the formation of a biofilm, which leads to the further growth of the organism and its resistance to the antibiotics that we give. The other important thing to remember is that in an ICU setting, we ourselves are also helping propagate this infection. About 30 to 40% of all nosocomial infections are attributed to cross transmission, and this actually is a challenge in most ICUs. If you look at basic environment in our ICU, whether it be the IV set, the computers, the telephone, or various other devices, all of these have been shown to grow or recover MRSA, and this is true for even the beds, the stethoscope, or the blood pressure apparatus. And there have been enough studies which have shown that this actually would lead to a colonization and transmission of staph from one person to the other. This is just to give you an example that if you have an uncolonized patient who comes to your ICU, if there is inappropriate antibiotic use, this will lead to colonization, and you will have a colonized patient. You could also have a colonized patient if you take a transfer from another hospital. This colonized patient, if he comes in contact with a healthcare worker who is VRE free, because of contamination, this person can become a contaminated healthcare worker, and he then can act as a source of transmission to an uncolonized patient or an uncontaminated patient who can then become contaminated and therefore lead on to a perpetual cycle. The only two ways that can aggressively stop this is, of course, antibiotic restriction or appropriate antibiotic use and regular hand washing, which can break the cycle. And this has actually been shown in large number of studies that if you have a healthcare worker with VRE free hands, and if he visits a VRE positive origin site, he can himself become infected and therefore become the source of transmitting the infection. And in this study, it was actually shown that almost 10% of transmissions were occurring in the ICU because of the healthcare workers. And out of the 16 transfers that they were able to document, 13 occurred in rooms of unconscious patients. That means patients who were unable to spontaneously touch their immediate environment, and therefore it had a direct relationship with the healthcare worker. So we need to keep this in mind, especially when we are treating gram-positive infection in an ICU, that there is a very high chance of transmission occurring. And basically the challenge, therefore, is to use initial non-pharmaceutical measures like hand hygiene, improve the hospital environment. Some debate, but not very concrete evidence about isolation of MRSA patient, where that helps in a big way in preventing the transmission in an ICU setting. But surveillance is very important, and antibiotic stewardship is another very crucial factor as far as treatment and prevention of gram-positive infection is concerned. When we come to the drugs that we have a whole list of treatment options, including vancomycin, teicoplanin, linezolid, daptomycin, tigecycline, and daflopristine with quinipristine. There are a lot of newer drugs which are also being evaluated and are in the pipeline and should be available in the near future. If you look at vancomycin, it has a good spectrum of activity against gram-positive cocci, and as of now still remains in majority of patients the drug of choice for MRSA infection. Most streptococci are susceptible to it, and it has a good anaerobic activity also. However, there has been, like I have shown you, reports of resistance which are emerging, and this is basically in enterococci because of 5 subtypes. And along with that, there is an issue of what is known as tolerance. That is this is a mechanism by which there is a decreasing bactericidal activity. If you look at data from India, and this is one study which looked at the prevalence as far as India is concerned, and this looked at the H vancomycin intermediate sensitive staph aureus, that is the hetero-resistant subtype, and this was found to be almost around 6.3% as far as Indian data is concerned when they looked at the resistance as far as Asia is concerned. And interestingly, if you look at this data, the data from India tends to show that India has a much higher pattern of resistance as compared to the other countries. The other 2 countries which have a higher resistance is actually Japan and Korea. There's also an issue of what is known as creeping MIC levels, increasing MIC level that have been reported as far as vancomycin is concerned. There's a shift in the MIC level from 0.5 to greater than 1 over the last few years, and this has been shown in this chart that the MIC levels have gradually started becoming more as far as vancomycin is concerned, and this is directly related to your efficacy of treatment. And as has been shown, that the success of treatment actually comes down significantly if your MIC level goes up to to greater than 1. And a recent article in Chest has actually demonstrated that. This is published last year, which looked at 160 patients who had MRSA, which was associated with hospital-acquired pneumonia, ventilatory-associated pneumonia, and healthcare worker-associated pneumonia. And they found that in the MRSA, the majority of the MIC was more than 1.5, that is in around 72%. And based on analysis, they were able to show that there was an increase in 28-day mortality when the MIC level rose from 0.7 to 3 micrograms per ml, and this was significant. So a higher requirement of MIC as far as vancomycin is associated with higher mortality and a poorer response. Moving on to teicoplanin, again the mechanism of action is similar to that of vancomycin, but again a very good drug as far as MRSA is concerned. The other molecule which has in the market, and luckily in our country is available at much cheaper cost, because linezolid abroad is much more expensive than vancomycin, and that has limited its use abroad. It's the other way around in our country, where linezolid is much more cheaper as compared to vancomycin. And this is again a good drug, the advantage being that it can be given parenterally and orally, and it is bacteriostatic against enterococci and staph, but otherwise it has a good penetration in lungs and tissue. If you look at the Infectious Disease Society of America, it is the drug of choice for empirical therapy for MRSA, VAP, and also it's an option for patients who have renal impairment, because vancomycin has an issue of nephrotoxicity. It can also be considered, because of its oral preparation, as an outpatient treatment for MRSA, and again for an alternate therapy in patients who are allergic to beta-lactams and vancomycin. The newer drug which is also available is tigecycline, again a derivative of minocycline. The advantage of this drug is that it's not a pure gram-positive antibiotic. It has a gram-positive and gram-negative activity, and therefore is useful when you're looking at a broad spectrum of antibiotics. And it is not affected by common resistance mechanisms. I'll just take another minute or so. And it is actually improved by the FDA in complicated skin and soft tissue infections, intra-abdominal infections, and is being evaluated in community-acquired and nosocomial infection. So tigecycline has the advantage that it has good cover as far as gram-positive, gram-negative, and anaerobes is concerned. The only disadvantage is that if you're looking at a broad spectrum cover, it doesn't have a very good cover as far as Pseudomonas is concerned. But if you look at clinical cure rates, they are pretty similar to that of vancomycin or imipenem celestine when it is used in skin and soft tissue infection or complicated intra-abdominal infections. Data from our center, which had looked at the utility of tigecycline in our center, found that all isolates of MRSA and VRE that were tested were sensitive to tigecycline, and as of now, we did not find any resistance for tigecycline. Daptomycin is the other drug which is available. Again, it has no low incidence of side effects and has a good gram-positive activity. Again, approved for complicated skin and soft tissue infection and for right-sided endocarditis, it has also been recommended. The problem with daptomycin is that it is not good for lower respiratory tract infection because of the interaction with surfactant. There is a significant loss of its potency when surfactant is present, and it becomes, if the level of surfactant is more than 1%, the drug is not useful. So it is not a drug to be given for gram-positive low respiratory tract infections. Again, data from our center tends to show that it is useful. Studies from our center have shown that it has excellent activity against Staph aureus, regardless of resistance to methicillin or quinipristine and daflopristine. Quinipristine daflopristine is another molecule which is more expensive, has more side effects, and therefore of not much use. We have a large number of newer drugs which are also there. They are the glycopeptides. We have a newer beta-lactam which has got MRSA activity, ceftobiprole, which is also being available, should be available shortly. And these new drugs do hold promise as far as these patients are concerned. But the treatment challenge is that we have new drugs. Should we reserve these new antibiotics for more severe or resistant patients, or should we use them as first-line drugs? The advantage of reserving them is that it will prolong the activity of the antibiotic because you're using it as a reserved drug. The disadvantage is that we all know that prompt initiation of effective antimicrobial therapy is associated with better outcome. So if you wait too long and then start the antibiotic, you may have a higher chance of mortality. Hence, there is an increasing pressure in most clinicians to prescribe antibiotics that are active against multi-drug resistant pathogens. Also, there is an argument that using old antibiotics will create a selective pressure to allow the growth of multi-drug resistant pathogens and therefore cause problems in the near future. This dilemma is actually not really is difficult to solve, and there is no real data to help decide what should be the policy that one should follow. Conventional preclinical lab data has been shown to be a poor predictor as far as in vivo risk is concerned, and we need to have better lab tests to guide not only drug development, but help us to predict clinical scenarios where resistance is more likely to occur, so that in the very beginning one can use drugs which have which are less likely to be resistant. The second challenge is, will antibiotic combination reduce resistance? Why not use two MRSA antibiotics rather than one? Will that help in terms of better survival? Again, additive and synergistic action has been shown in some studies. However, there have been some studies which have shown an antagonistic activity, especially studies using linezolid and vancomycin and linezolid and gentamicin. And it's important to remember that a lot of these studies are in vitro based, and in vitro data doesn't always go along with clinical efficacy. So I don't think we really have enough data to say that combination therapy is superior or will be anyway beneficial when we have more extensive gram-positive infection. But antibiotic combination will reduce the selective pressure for resistant mutants to either drug. The only thing is that they should consider the in vivo action, and the chosen drug should have similar tissue penetration. Those are basic things that one should do. So to conclude, basically, gram-positive infections are a cause of concern in most ICUs, and as I've shown, antibiotic resistance is developing not only abroad, but there are emerging data from our country to show that even in among gram-positive pathogens, resistance is rapidly emerging. We need to really take care of preventive measures, including infection control, preventing the spread from healthcare workers from one patient to the other, and a judicious use of antibiotic is needed. Newer antibiotics are being developed to tackle the resistance problem, but there have to be appropriate use, as I've already shown that there are some certain issues as far as that is concerned. And we don't have too many drugs in the horizon, so we need to remember that we have a limited stock of drugs, and therefore we need to make the best use of them. Thank you very much.